I'm going to be doing a presentation more about how to do and order things in Epic. It's going to be less about the medicine and more about the logistics of how to do things in the ER. So the first thing to address is going to be CT scans. I've been asked to address CT scans versus CTs with contrast versus CTAs. How do we know when to do what? What does that look like? So let me show you. So generally speaking, go to the orders tab here. So in this example patient, say she was in a car accident, she hit her head, lost consciousness. The two most important things that I want to order is a CT head without contrast, and a CT cervical spine without contrast. And the reason for that is going to be in this patient with traumatic head injury or traumatic neck pain, the CT of the head without contrast is going to look for blood, and then the CT cervical spine without contrast is going to look at the integrity of the bone. So the non-contrast is looking for internal bleeding and the bone structures themselves. Let's talk about another patient. In this patient with abdominal pain, we'll go to the order tab. When it loads. So imaging for this individual, she's having abdominal pain. Generally speaking, 95% of the time, you're going to be doing a CT of the abdomen and pelvis with IV contrast. And the reason for doing with IV contrast in the majority of these cases is just because there's so many structures in the abdomen, and that the contrast is going to give us a better view of things like fat stranding, fluid collections, abscesses, and we need that extra contrast because we're not just looking at just the bones or just for internal bleeding. We're looking for a lot of things. So 95% of the time, you're going to be using a CT of the abdomen and pelvis with IV contrast. Occasionally, you'll get a call from CT that the patient is pregnant or that their creatinine is too high and their kidney function's too poor, and they want us to rethink the CT with contrast. But 95% of the time, that's your go-to for abdominal imaging. Similar for flank and this patient. Old person with rectal bleeding. He's anemic. Say he's on blood thinners. Now, in this scenario, I'm going to be looking at the arteries. The CT angiogram, the A is looking at the arteries. So in this individual, an old man, I want to look for the integrity of the arterial blood vessels to his bowel and the abdominal aorta itself. So I do CT abdomen pelvis. I do like a CTA of the abdomen, right? And again, that A is, it doesn't stand for artery, it stands for angiogram. But if that helps, think of it as artery, whereas the contrast primarily goes into the venous system. CTA of the abdomen goes into the abdominal artery. If I was doing pulmonary embolism workup, I'd do a CTA of the chest. And then last but not least, if we have a patient that we think is having a stroke, with neurologic deficits for whatever reason, the very first thing you're always going to get is a CT head without contrast. And again, just like we talked about, to make sure there's no hemorrhage. Make sure there's no subarachnoid hemorrhage, subdural hemorrhage, anything hemorrhagic in nature. So if we have the CT of the head and it's negative for a bleed, but he's still having neurologic deficits, I want to look at the integrity of the blood vessels going up to the brain. So I will be doing a CTA of the head and neck. If it lets me. And CTA of the neck. And so again, that is to get evaluate for any hemorrhagic stroke. These two to look at the blood vessels going to the brain, checking out your carotid, your internal carotid, your external carotid, and the middle cerebral and cerebral artery, all that good vasculature. So that is the rundown on imaging, who needs CTs, who needs CTs with IV contrast, who needs CTAs. We will go on ahead. I want to show you guys some other specific orders just so you know what they look like when it comes time for you to order them. I have this man, he's 70, he has chest pain. The majority of the time, if he hasn't already gotten aspirin, we're going to be giving him more aspirin. And in the emergency department, we actually give 4 baby aspirins, so it ends up being a 324 milligram full dose aspirin. And say he has an elevated troponin, and I talked with my attending, and we want this guy to be on a heparin drip, and he's having chest pain, so I want him to be on a nitro drip, and his blood pressure is real high. I will do a heparin drip. And then there's two forms of the heparin drip. There's one for like coronary artery disease. This one, coronary artery disease, STEMI and STEMI, unstable angina, and AFib. Whereas the other heparin dose is primarily used for clots. So in this patient who's having chest pain, I'm going to be using this order set to, among other things, make sure that I have the heparin boluses and the heparin drip ordered. So if you want, you can try to put all of that in the administration orders, but save yourself some time and just let this order do it for you. And that way you won't screw anything up. The more labs, the more drips, the more tests, the more likely that you're going to get something wrong if you type it all in. So if the order set is available, do it. Keep in mind that not all order sets are perfect, and you're still going to have to double check to make sure you're not ordering something that is nonsensical. But for the most part, when it comes to complicated things like strokes or dissections or starting heparin drip for chest pain, there will be order sets for that to make your life easier. And then you can start the nitro drip on him. The nitro drip, you're going to be seeing this titratable infusion. And this is typically what the order will look like. You'll start low, keep titrating up, at least until the pressure is under control or until the chest pain is relieved. And again, all of these instructions auto-populate if you use the orders properly. So that would be what it looks like to start this patient on a nitro drip and a heparin drip. And of course, I would sign the orders and speak with the hospitalist to get them admitted. Talking about another special kind of order set. If you had to do a pelvic examination, for example, this might not be what it's called in actual Epic, since this is Epic Playground. But here, say this lady has abdominal pain, and I'm going to order all of these tests. And we're going to do a pelvic exam, so I'm going to do a wet prep. I'm going to communicate to the nurse that I'm doing the pelvic exam to get the materials ready. We're going to be collecting a sample for gonorrhea and chlamydia. We're going to be having a serum qualitative study for HCG. We're doing a KOH to evaluate for yeast infection, and the wet prep for BV. So that's something, what it would look like. Again, don't use a urine dipstick. Don't use urinalysis. Use urine with reflex to culture. Very good. If I have a patient with a laceration and I need to order lidocaine, I will order the lidocaine with epinephrine typically, which I will be ordering into the dermis. So I can suture up this gentleman's laceration. So that's what the lidocaine with epi order looks like, and then you can just ask the nurse to quickly grab you a vial of lido with epi. If, for example, you have a patient with eye pain, that's not what I wanted. There is an ophthalmic solution to numb the eye. That's what it would look like. So if you have somebody coming in with eye pain, eye injury, just get in there, give them the numbing eye medicine so they are not miserable, because nobody wants their patients to be miserable. If you have a patient with a nosebleed, you're going to be ordering Aspirin and a specific kind of intranasal TXA. There's all sorts of special things you can do. And then last but not least, I wanted to go over what the majority of your symptomatic control is going to look like. So we're back to our 28-year-old female with abdominal pain. For the most part, patients that have an IV and have nausea, you're going to be giving 4 milligrams of IV Zofran. Boom. Now when it comes to pain control, there's options. The majority of abdominal pain patients that I see will end up getting, for example, 4 milligrams of morphine. That's a comfortable place for most providers. If your patient is old, say this would be, a 90-year-old with abdominal pain, then they would be meeting the Beers criteria, which basically means old people are more sensitive to heavy doses of pain medication, in which case I would not start at 4, I would maybe start at 2. Right? If I have a patient who comes in with a sprained ankle, I'm just going to give them a little bit of Toradol. You can do, if they don't have an IV, just do a quick IM. If they do have an IV for whatever reason, you can use that. But if they're here for an isolated ankle injury, they probably won't have an IV, so just be aware of that. Another medication for pain management is fentanyl. 50 IV is usually a pretty good starting point for most comers. Fentanyl acts quickly, which is why we like it for when somebody comes in and you can tell that their arm is broken or their arm's out of place or they just got in a car accident and they're obviously in pain. You can just give them a quick 50 microgram dose of fentanyl for some quick acting pain relief without overdoing it. And I guess that's all I have for right now. I apologize for the low production quality, but I did the best I could. Hopefully this is helpful. And rate me 5 stars.